Okay, let's unpack this. Imagine a time, and it really wasn't that long ago, when the mere thought of performing surgery on a human fetus, still inside the womb, it was considered, and this is a quote, radical and heretical by the medical community. Honestly, it sounded like pure science fiction, something really out there. Yet somehow, incredibly today, that seemingly impossible idea, fetal surgery, it's transformed. It's gone from like a fantasy to a remarkable, sometimes even standard medical practice. So in this deep dive, we're going to explore the incredible history, the pioneering innovations, the really profound ethical questions, and the truly groundbreaking future of operating on our absolute tiniest patients before they're even born. We'll be drawing on excerpts from a leading surgical textbook, which gives us a really solid base for this. Our mission, to pull out the most important bits of knowledge, aiming for those real aha moments that show just how far medicine has pushed the boundaries and maybe where it's heading next.
And what's just fascinating right from the beginning is the sheer unique complexity of it all. From the very start, fetal surgery had this profound guiding principle, the idea of two patients in every intervention. And that's not just, a logistical thing. It's a deep ethical and practical point that raises the stakes higher than almost any other kind of surgery. We're talking about huge implications, especially for maternal safety. That was, and absolutely still is, the number one concern, guiding every single step. And, often these interventions are needed precisely because the fetal condition is so severe it can cause devastating problems like hydrops. That's a severe, often life-threatening buildup of fluid all through the baby's body, which tells you there's profound organ failure happening.
Right. So to really get where we are today, we need to step back to the very dawn of this field, before these big breakthroughs made surgery on the unborn seem possible. Before 1981, procedures inside the uterus were, well, pretty limited. We're mostly talking diagnostic stuff like amniocentesis, taking a fluid sample for genetic tests. Or maybe very specific percutaneous treatments, like giving blood transfusions inside the womb for severe blood issues like Rh disease.
All right, erythroblastosis, yeah, where the mother's immune system attacks the baby's red blood cells. Really serious stuff.
Exactly. And those were revolutionary, no doubt. But they weren't surgery as we usually think of it, openly fixing an organ or a defect. Then came 1981, a real pioneer, Dr. Michael Harrison at the University of California, San Francisco. He basically dared to go where no one had gone before. He performed what many thought was just impossible.
Yeah.
The very first open fetal surgical intervention on a fetus still inside the mother. He was treating a severe urinary blockage, obstructive uropathy. Can you imagine the pressure, the skepticism, the hopes riding on that? And tragically, that first tiny patient didn't survive long after birth.
Heartbreaking.
Yeah, and that setback could easily have just crushed the whole idea, right? Maybe labeled fetal surgery as just too dangerous, too experimental. But this is where you really see the incredible perseverance of those early pioneers. Their second attempt, it was a success, a triumph. Both mother and baby not only survived, they thrived.
An amazing moment.
You have to imagine the relief, the sheer joy for that team, and that very first successful fetal patient. He's now a healthy young man in his 40s. A living testament to that struggle and that breakthrough. That one success didn't just set the stage. It really built the whole foundation for this new specialty.
It absolutely did. That moment really marked the birth of a whole new surgical specialty. And when we say the unthinkable became reality, it's not hyperbole. The obstacles were just immense, beyond the massive technical hurdles of operating on such a tiny, delicate patient inside, a living, moving person. There were huge ethical charges, like you said. Many people felt it violated the sanctity of the womb, a dangerous intrusion. It wasn't just medical, it was deeply philosophical. But their success wasn't built on just hoping for the best. Quite the opposite. It came from really diligent, painstaking preparation. Rigorous, large animal modeling, sheep especially, turned out to be crucial. And lots of frank, sometimes really difficult, multidisciplinary conversations. What's fascinating is how they systematically tackled the core technical problems. They had to figure out totally new ways to safely open the uterus without causing massive bleeding, how to keep the uterus relaxed during the surgery so the fetus was stable, how to get a watertight closure afterwards to stop amniotic fluid leaking, and critically, how to stop preterm labor after the operation. That was a huge one.
Right.
All these techniques, which are standard now, they were meticulously worked out in animal models first, years of work. And it absolutely required incredible teamwork. This wasn't one heroic surgeon. It needed neonatologists, perinatologists for high-risk pregnancies, radiologists for the imaging, anesthesiologists managing both patients, plus vital partnerships with biomedical companies to develop new tools. It was this massive collaborative effort that made it possible.
It's just astonishing when you think about that early struggle, the ethics, the sheer technical guts it took. And despite thousands of these procedures now having been done worldwide, there are, amazingly, few known maternal deaths worldwide that can even be remotely linked to a fetal procedure.
Yeah.
That, to me, is a truly remarkable safety record. It speaks volumes about the careful development, the strict patient selection.
Absolutely. Very careful.
And we absolutely have to acknowledge, as the sources point out, that this field even exists, let alone thrives, largely because of the extraordinary bravery of the many women who faced the unknown, the risks, and chose these procedures for their children. So thinking about all that, how did this once radical idea get so successful, so safe? What really turned the tide?
That's the key question, isn't it? The journey started with a core hypothesis, the basic rationale for fetal surgery. The idea was, well, pretty simple on the surface. If a fairly straightforward anatomical defect happening in utero could lead to really disastrous, often fatal, problems after birth, then fixing that anatomy before birth should, theoretically, normalize the baby's physiology once born. For instance, if a blocked urinary tract meant underdeveloped lungs after birth, then clearing that blockage in the womb should let the lungs develop properly. Simple idea, right?
It's logical.
But the reality, it turned out to be not as straightforward as they had hoped, mainly because of the challenges of actually getting to the fetus safely and then closing the uterus securely without triggering preterm labor. And as we've said, maternal safety was always paramount. So initially, these interventions were only considered for conditions that were uniformly lethal, meaning conditions where the baby had basically zero chance of survival after birth. Only then was the potential benefit to the fetus seen as enough to justify the very real surgical risks to the mother. Remember, she's undergoing major surgery with no direct medical benefit to herself. That principle drove the very cautious early steps of the field.
So, given those huge challenges early on, the difficulty of operating, the epical wait, what was the big turning point? Was there one specific technology or breakthrough that really unlocked the potential here?
Oh, absolutely. The real game changer, the disruptive technology that completely transformed everything, is something we almost take for granted now: ultrasound.
Ultrasound, right.
Before ultrasound, the fetus was, largely a mystery, a shadow. Doctors guessed based on the mother's condition. Ultrasound, though, gave us non-invasive, real-time observation. It let doctors map out normal fetal development with images. And critically, it allowed them to precisely see and document abnormal variants, the specific defects affecting the fetus. This ability to literally see inside the womb didn't just help diagnose things. It fueled a crucial new question. Could fixing a defect before birth actually change the fetus's pathophysiology, the way its body works, and improve the outcome?
I see.
Ultrasound was the window that let us even dare to ask that question, and then try to answer it. And to answer that critical question, you absolutely cannot overstate the role of animal models. The fetal ovine model, sheep, became incredibly important.
Sheep? Why sheep?
Well, sheep fetuses have this unique biological quirk. They're remarkably resistant to preterm labor and spontaneous abortion compared to other animals. This meant researchers could perform multiple interventions on the same fetus without losing the pregnancy or needing complex drugs to stop labor called tocolysis.
Wow, okay. That's a huge advantage.
A massive scientific advantage. So the imperative was clear. Rigorous investigation in various animal models, lambs, rodents, primates too, was absolutely essential. Without all that extensive preclinical work, meticulously testing every technique, understanding every response, the jump to safe and successful human fetal surgery just wouldn't have happened, period.
But even with those incredible advances, the diagnostics, the animal work, the journey still had these critical considerations, particularly for the mother. We have to keep coming back to that ethical tightrope. Unlike almost any other surgery, fetal surgery involves two patients, and the benefits to the fetus must justify the significant, very real risks to the mother who gets no direct medical benefit. It's a unique spot to be in ethically.
Constantly being weighed.
So it makes sense that the maternal health requirements are strict. Mothers need to be in reasonable health, no major underlying conditions that would make major surgery too risky. But what's often surprising, I think, are the specific maternal risks that are still pretty substantial. We're talking serious complications, bleeding, chorioamnionitis, that's a severe infection of the amniotic fluid and membranes.
Very dangerous.
Placental abruption, where the placenta detaches too early. PPROM, premature rupture of membranes, the water breaking too soon, and of course preterm labor itself, leading to premature delivery. And crucially, there's the hysterotomy, the incision in the uterus. Open fetal surgery usually requires what's like a classical C-section incision. This is not the modern low transverse incision most women get today, the bikini cut in the lower part of the uterus.
That's a critical distinction.
Right, because that classical hysterotomy higher up in the muscular part significantly increases the risk of uterine dehiscence, the scar opening up, or even uterine rupture, not just in that pregnancy, but in all future pregnancies.
Lifelong implications.
Exactly. It means future births must be C-sections, and the risk is always higher. There's data from the North American Fetal Therapy Network and AFTUNet. Their registry review showed a 9.6% uterine rupture rate in later pregnancies after open surgery for myelomeningocele, MMC.
Which is similar to historical classical C-section rates, yeah.
It just highlights the significant lifelong impact on the mother's health. It's something surgeons are constantly balancing, that long-term maternal risk versus the potential benefit for the baby.
And that concern absolutely extends to maternal fertility. That was actually a historical problem, a kind of Achilles heel early on. Initial attempts using standard surgical staplers to open the uterus in primate models actually caused infertility.
Right.
They found the staples basically acted like a permanent IUD, preventing future pregnancies, so they had to innovate. A unique, absorbable stapler was developed, working closely with Ethicon, a medical device company. And recent surveys looking at mothers who had fetal surgery and then later had successful pregnancies show no statistically significant difference in their fertility rates compared to before the fetal surgery. That's a huge step forward. It meant women could safely conceive again.
That's incredible progress.
Huge progress. However, the enduring challenge, the real Achilles heel that still exists for fetal surgery, is the control and prevention of preterm labor. While we've made progress, we don't have a foolproof way to stop it yet. This means we always have to weigh the added risk of prematurity for the baby against the potential benefit of fixing the condition before birth.
Right, because being born too early brings its own set of serious problems.
Exactly. A baby born very prematurely might have complications that outweigh the benefit of the fetal surgery itself. So what's the real takeaway here for you, the listener? It just underscores the immense complexity. The dedication required not just for the baby's outcome, but for managing the profound implications and risks for the mother. With that critical foundation laid, let's pivot now. Let's look at the amazing range of specific conditions that are actually being treated with these extraordinary fetal interventions, maybe going system by system.
Okay, let's start with one of the biggest success stories, something affecting the neurologic system, myelomeningocele, or MMC, which most people know as spina bifida. This is truly a devastating condition. In the U.S., about 4 children are born every day with MMC. It's one of the most common birth defects causing paralysis. And the consequences are profound, lifelong. Paralysis, depending on where the spinal defect is, often needing wheelchairs or braces, bowel and bladder incontinence, requiring lifelong management, severe musculoskeletal deformities, significant cognitive disabilities sometimes. And historically, many also had immediate problems like hindbrain herniation, where part of the brain gets pulled down, and hydrocephalus, that fluid buildup in the brain, often needing shunts and posing a major risk.
Right. And to grasp why prenatal repair for MMC is so powerful, it helps to understand the two-hit hypothesis of the injury. The first hit is the initial embryonic problem. The neural tube doesn't close completely, leaving the spinal cord exposed early in development. We think it's a mix of genetic and environmental factors. That's why folic acid during pregnancy is so important now. It helps prevent these defects, though it doesn't eliminate them entirely.
Okay, so that's the first hit. What's the second?
The crucial second hit happens while the baby is still in the womb. The exposed, very delicate spinal cord and nerves get damaged further. There are 2 main culprits. First, just mechanical trauma rubbing against the uterine wall. And second, really critically, chemical trauma from the amniotic fluid itself. It turns out amniotic fluid is surprisingly toxic to that exposed neural tissue over time.
Really? Amniotic fluid?
Yes. This constant chemical exposure and rubbing contributes significantly to the neurological damage. It's also what drives the hindbrain herniation and hydrocephalus development. So the revolutionary goal of prenatal surgery is to close that spinal defect before birth, to protect those nerves from that secondary ongoing trauma, essentially preventing the second hit.
That makes so much sense. And this leads us right to the landmark MOMS trial. This is a massive moment for the field, wasn't it?
Absolutely pivotal. The management of myelomeningocele DS study MOMS. It was a randomized controlled trial, rigorous science comparing fetal surgery versus standard postnatal repair. And this wasn't small scale. Top places were involved: UCSF, Children's Hospital Philadelphia, CHOP, Vanderbilt, all working with the NIH.
And the results were?
So dramatic, so overwhelmingly positive for prenatal repair that the Safety Monitoring Committee actually stopped the trial early.
They stopped it early.
Yes, at 183 patients instead of the planned 200. Because it was considered unethical to keep assigning patients to the postnatal group when the benefits of fetal surgery were so clear and compelling, the evidence was just undeniable. The results were, frankly, revolutionary. First, safety. No maternal deaths in either group. Only 2 perinatal deaths in each group, so the procedure itself was safe for both. But the difference in needing a ventriculoperitoneal shunt, that brain drain for hydrocephalus by 12 months, huge. 68% in the prenatal group needed monitoring for it versus 98% in the postnatal group. And actual shunt placement, 40% prenatal versus 82% postnatal. Hugely statistically significant. Fewer brain surgeries for these kids.
That alone is massive.
Massive.
Yeah.
But it wasn't just shunting. The trial showed significant functional and neurologic improvements at 30 months old in the kids who had surgery before birth. They had a better ability to walk without devices or braces, 42% in the prenatal group versus only 21% postnatal, and significantly less hindbrain herniation at 12 months, 64% prenatal versus 96% postnatal, less severe brain impact. And interestingly, even though the prenatal surgery group on average had anatomically more severe spinal lesions, they still had better motor function.
Wow. So what does this really mean for someone listening?
This trial wasn't just a win for spina bifida. It fundamentally changed the scope of fetal surgery. Before MOMS, like we said, interventions were almost exclusively for lethal conditions where survival was the goal. This trial proved we could intervene safely and effectively for a condition that, while devastating, wasn't immediately fatal.
That's the key shift.
That's the profound aha moment. It opened the door to preventing lifelong disability, not just saving a life. It challenged everyone, doctors, families, to ask if the risks of fetal surgery were justified, not just for survival, but for a dramatically better quality of life. That philosophical shift, that's the real game changer. And long-term follow-up is still ongoing, looking at motor function, neurologic outcomes, bowel and bladder control, all crucial for quality of life.
Okay, with that incredible story showing the potential to really improve quality of life, let's shift. Let's talk about other conditions where hydrops, that severe fluid buildup we mentioned, is a major life-threatening issue. First, under tumors causing hydrops, there's sacrococcygeal teratoma, or SCT. This is one of the most common congenital tumors found at the baby's tailbone, and they can get huge, sometimes bigger than the baby's head. They're highly vascular, lots of blood vessels. This causes massive shunting blood flows through the tumor instead of the rest of the body. This puts a huge strain on the fetal heart, leading to high-output heart failure and that non-immune hydrops. When these are found before birth and hydrops is present, the mortality rate is nearly 50% if untreated.
Very grim prognosis.
So interventions can include open fetal resection, surgically removing or reducing the tumor size in utero, or minimally invasive things like radiofrequency ablation or laser to reduce blood flow. Outcomes are mixed. The sources say 38% to 75% survival, but that's way better than the maybe less than 10% survival if you do nothing for these hydropic SCTs. Okay, next, in the neck chest area, we have cervical teratoma. These are neck masses found before birth. They can grow large enough to compress the trachea, the windpipe, and the esophagus, the food pipe. This blockage stops the baby swallowing amniotic fluid properly, leading to polyhydramnios, too much fluid, which can trigger preterm labor. And if the tumor is very vascular, it can also cause heart failure and hydrops in utero. The critical intervention here, and for other airway blockages found before birth, is something called the ex utero intrapartum treatment, or exit procedure.
Right, the exit procedure.
Now, it's really important to get this. An exit procedure is not just a C-section. People often mix them up, but the difference is vital, life-saving.
Completely different goals.
Exactly. In a normal C-section, you want the uterus to contract afterwards to stop bleeding. But in an EXKI, you need deep maternal anesthesia to keep the uterus completely relaxed the whole time. And critically, to keep the uteral placental circulation going.
Maintaining that lifeline.
Right. The umbilical cord stays intact. The baby keeps getting oxygen from the placenta. You don't want the baby to start breathing on its own too early. Uterine contraction during an exskeet would be bad for the baby and risky for the mother. So during an exskeet, they deliver the baby's head and neck while it's still connected to the placenta. This gives the surgical team precious time, minutes, sometimes even an hour or more,
That's quite remarkable.
to secure the airway. Using scopes, maybe doing a tracheostomy, or even removing the mass itself, that specific part is called exatetal resection. Only then do they cut the cord, deliver the baby fully, and it needs to breathe independently.
Fascinating procedure. Now, moving on to other chest issues, we have congenital lung lesions. This covers a whole spectrum, from small cysts that cause no problems to huge masses that can sadly lead to fetal demise. Just like with teratomas, if non-immune hydrops develops, it's a very bad sign. It means the lung lesion is seriously affecting the baby's circulation. Management varies. Sometimes maternal steroids can actually cause these lesions to shrink rapidly and reverse the hydrops. That's been a big advance for some benign types. For lesions with large cysts, minimally invasive drainage might be tried, using ultrasound guidance to either aspirate the fluid or place a thoracoamniotic shunt, a tiny tube draining fluid from the chest into the amniotic space.
Do those shunts stay put?
Often not, unfortunately. Shunt dislodgement is common, sometimes needing repeat procedures. Open fetal surgery for lung lesions is pretty rare now, usually only if the baby is about to die and there are no other options. The EXI procedure is often used to help manage the transition at birth for babies with large lesions. Then there's congenital diaphragmatic hernia, or CDH. This is a relatively common defect in the diaphragm, the muscle separating the chest and abdomen. This hole lets abdominal organs, intestines, liver, stomach push up into the chest. This squashes the developing lungs, leading to severe pulmonary hypoplasia, underdeveloped lungs that can't work properly after birth. And pulmonary hypertension, high blood pressure in the lung arteries? CDH is often linked with other problems too, which contributes to its high mortality rate.
Didn't they try open repair for CDH early on?
They did. Open fetal repair was attempted, but it was largely abandoned because survival rates were poor in the most severe cases. One theory is that when they pushed the organs back into the abdomen, particularly the liver, it could kink the blood vessels, causing liver damage. So the focus now for severe CDH has shifted to tracheal occlusion.
Blocking the windpipe, how does that help?
It sounds counterintuitive, right? But the idea is innovative. By temporarily blocking the fetal trachea, the fluid that the fetal lungs naturally produce gets trapped inside. This fluid buildup creates internal pressure, which encourages the lungs to grow pulmonary hyperplasia, trying to overcome that underdevelopment, the hypoplasia, which is the main killer in CDH.
Has it worked?
There have been promising results, particularly in Europe. U.S. clinical trials are ongoing. However, the initial large U.S. trials didn't actually show a survival benefit. So it highlights just how complex CDX is and how challenging it is to get consistently good outcomes. Still an active area of research.
Okay, let's move to the heart and circulatory system. This is a newer, rapidly evolving area, right? Congenital cardiac lesions.
Very much so. Still relatively new territory.
And the goal here isn't necessarily to fix the heart completely before birth.
Not yet, no. That's currently beyond what we can do. The goal is more about increasing the chances of the baby having biventricular circulation after birth, both sides of the heart pumping effectively, and also trying to slow down the progression of really severe heart defects that have extremely high mortality rates otherwise. The hope is that intervening early might rescue heart function, improve pulmonary circulation, and maybe lead to better outcomes after birth, perhaps avoiding complex stage surgeries, or at least improving the odds.
But it sounds like there are limitations.
Definitely. There aren't many eligible patients. Referrals often come late to the few specialized centers that can do this, and there's just a shortage of providers with the incredibly specialized expertise needed.
So what procedures are being done?
Right now, it's limited to minimally invasive techniques done through small incisions. Things like balloon valvuloplasty, opening up narrowed valves, and atrial septoplasty, creating a hole between the heart chambers. These are for specific conditions like severe aortic stenosis, pulmonary atresia with an intact ventricular septum, and hypoplastic left heart syndrome, where the left side of the heart is critically underdeveloped. While more patients might be achieving that biventricular circulation, we haven't yet seen definitive proof of significantly improved long-term survival for the most severe defects. Open fetal heart surgery, that's still purely experimental, only in animal models, shows how tough this area is.
Okay. Let's cover another major area, and actually one of the most common reasons for fetal intervention. twin transfusion syndrome, or TTTS.
Yeah, TTTS is a big one.
It affects about 1 in 50 twin pregnancies in the U.S. That makes it the leading reason for operative fetal intervention, around 500 cases a year. Can you explain what's happening in TTTS?
Sure. It happens in monochorionic twins, identical twins who share a single placenta. The problem is unbalanced connections between their blood vessels on the surface of that shared placenta called vascular anastomoses. This leads to one twin, the donor, basically pumping too much blood across to the other twin, the recipient.
So one gets too much, one gets too little.
Exactly. And this imbalance causes major problems. The donor twin gets dehydrated, leading to oligohydramnios, too little amniotic fluid. The recipient twin gets overloaded with fluid, leading to polyhydramnios, too much amniotic fluid. This can cause them to grow at very different rates, heart failure in the overloaded recipient twin, high drops, and ultimately the death of one or both twins if it's not treated.
And the intervention.
The standard treatment now is fetoscopic laser ablation of those communicating vessels. It's usually done between 16 and 26 weeks of gestation. Using a tiny scope, a fetoscope, they go in and use a laser to very precisely seal off those abnormal blood vessel connections on the placenta.
Does it work well?
Outcomes are significantly better than doing nothing or just draining fluid. There's a much higher chance of at least one twin surviving, jumping from maybe 50% up to 75%. And it also seems to decrease neurologic complications compared to older treatments. But it does carry an increased risk of the membranes rupturing early and preterm delivery. Still, a major advance for these pregnancies. Okay, moving on to abdominal defects, let's talk about gastroschisis. This is a birth defect where the baby's abdominal organs, usually the intestines, are outside the body at birth, floating in the amniotic fluid, and it's actually becoming more common.
And that exposure to amniotic fluid is the problem.
It's a critical part of the problem, yes. While amniotic fluid is essential for normal development, it seems to be irritating, maybe even mildly toxic, to the delicate bowel when it's exposed like that. This causes inflammation, thickening of the intestines, and that leads to problems after birth, often delayed gut function. The baby struggles to digest food. This means long hospital stays, sometimes months, needing IV nutrition.
Is there any treatment before birth?
Currently, no routine in utero intervention. The usual approach now is just early delivery, around 36 to 38 weeks. The idea is simply to limit how long the bowel is exposed to that potentially harmful amniotic fluid. But what's exciting is that experimental animal studies in fetal sheep have shown that intervening in utero to either protect the bowel or return it to the abdomen is actually safe.
So why isn't it done in humans yet?
Well, gastroschisis is a major cause of short bowel syndrome, needing intestinal transplants sometimes. So the potential benefit of fetal intervention is huge, preventing that damage, minimizing those postnatal problems. But the challenge is predicting which babies are going to have the worst outcomes. We're not good enough at that yet to justify the risks of fetal surgery for everyone with gastroschisis, but it's definitely an area with future potential. And finally, let's touch on the genitourinary system, specifically lower urinary tract obstruction, or LA2. Fetal intervention for LA2 was actually one of the very first things attempted in human fetal surgery way back.
Why was that? What's the rationale?
It's pretty clear. If the urinary tract is blocked before birth, often by something like posterior urethral valves in boys, urine backs up. This backup can cause severe kidney damage, renal dysplasia. And critically, it means the baby doesn't produce enough urine, so there's not enough amniotic fluid. That lack of fluid, oligohydramnios, is disastrous for lung development. It causes severe pulmonary hypoplasia, underdeveloped lungs.
So the goal is to prevent the lung problem.
Primarily, yes. The idea is that if you can decompress the urinary tract before birth, let urine flow out, and restore normal amniotic fluid volume, you might allow the lungs to develop properly and prevent that fatal pulmonary hypoplasia. But it's really important to stress, most cases of LA2 actually don't need intervention. Many resolve on their own or aren't severe enough. Patient selection is absolutely critical here.
So how do they intervene?
Well, sometimes they do serial amnio infusions, putting fluid back in, but that's risky. More commonly, they place a vesicoamniotic shunt. It's a tiny tube placed percutaneously, guided by ultrasound, going from the baby's bladder out into the amniotic sac. It diverts the urine out, letting the fluid volume recover. There's also fetal cystoscopy, using a tiny scope to directly visualize and sometimes ablate or destroy the blockage like posterior urethral valves. That can potentially restore normal bladder function, too. It's fascinating how how they directly target the blockage to prevent that whole cascade of deadly problems. Understanding these solutions for existing problems really sets the stage for the next step, the truly exciting frontier of preventing or even reversing diseases at a cellular and genetic level. This is where the future of fetal medicine gets incredibly interesting.
Right. The journey we've traced so far, from an idea called radical and heretical, to a reality that saves and improves lives for lethal and non-lethal conditions. It shows just extraordinary progress. But while the achievements are huge, the future, as the source material says, really shines most brightly. It's filled with possibilities that kind of stretch the imagination. We're talking totally new applications. Understanding how adult diseases might start in the womb, developing sophisticated gene and stem cell therapies, even inducing transplant tolerance, teaching the fetal immune system to accept foreign cells. This next part is particularly compelling.
Absolutely. When we talk about in utero stem cell transplantation, you could argue the fetus is actually the ideal place for regenerative therapies.
Why is that?
Well, think about it. The fetus is already in this inherent regenerative environment. Cells are dividing, developing rapidly. And fetal stem cells themselves have superior plasticity. They can become many more types of cells and better differentiation abilities compared to adult stem cells. Plus, the fetal immune system is still developing, it's more naive, making it less likely to reject transplanted cells. It's a unique window of opportunity.
Okay, so what kind of stem cells are we talking about?
Let's start with hematopoietic stem cells, or HSCs. These are the stem cells from bone marrow that create all our blood cells. This makes them perfect for potentially curing genetic blood disorders like sickle cell disease, SCD, and thalassemia, THAL. Right now, treating these often means harsh postnatal bone marrow transplants. They require myeloablative conditioning, really tough chemo and radiation to wipe out the patient's own marrow first.
Brutal.
Very brutal. The advantage of doing it in utero IUHCT, or in utero hematopoietic cell transplantation, is that it's non-myeloablative. No toxic chemo needed. And crucially, it seems to induce something called mixed allogeneic chimerism.
Chimerism, like the mythical creature.
Sort of. It means the fetus develops cells from both itself and the donor coexisting peacefully. Its immune system learns to tolerate the donor cells. This allows the healthy donor cells to start producing the missing functional proteins. Then, a postnatal booster transplant, using cells from the same donor, can achieve really high levels of engraftment and actually correct the disease. Because the baby is already tolerant, making transplants much more feasible for many more patients.
That's amazing.
Even more amazing, using maternal HSC's stem cells from the mother might lead to even higher levels of chimerism and potentially allow for future organ transplants from the mother to the child without rejection. There was a stunning example in dogs where this allowed successful kidney transplants later in life.
Wow. Are there human trials?
Yes, there's an ongoing phase I clinical trial for thalassemia using maternal bone marrow HSCs delivered through the umbilical vein. Incredibly promising work. Then we have mesenchymal stem cells, or MSCs. These are different. They have trilineage potential. They can become fat, cartilage, and bone cells. They also have powerful immunomodulatory abilities that can influence the immune system. And while they were first found in adult bone marrow, we now know you can get really good MSCs from fetal sources like amniotic fluid and the placenta. Very versatile cells.
What can MSCs be used for?
A really powerful example is osteogenesis imperfecta, or OI. Brittle bone disease. It's a severe genetic disorder, a defect in type E collagen, the main protein in bone. This causes incredibly painful fractures, often starting even before birth. Preclinical work in mice was remarkable. First trimester fetal MSC transplants led to stronger, longer bones, thicker cortex, and a 2/3 drop in fractures.
And in humans?
Even more compelling. There are reports of 2 patients who received both prenatal and postnatal MSCs from the same donor. One patient, who used to break bones about once a year until age 8, had no new fractures for 2 years after getting an extra postnatal infusion. This allowed them to do things like dance, play hockey, gymnastics activities that would have been completely impossible before. A life-changing difference.
Incredible.
MSCs also have unique wound healing properties. This makes them interesting for conditions like gastroschisis, using an approach called TRACET, transamniotic stem cell therapy. Remember how the exposed bowel gets damaged by amniotic fluid? In rodent models, injecting concentrated amniotic fluid-derived MSCs into the amniotic fluid significantly reduced that bowel damage.
How does that work? Just putting more stem cells in the fluid?
Exactly. The idea is to boost the natural stem cells already present in the amniotic fluid. You're enhancing their wound healing and anti-inflammatory effects to counteract the fluid's toxicity to the bowel. It really highlights the dual nature of amniotic fluid. It can cause damage, but it also holds the keys to healing.
That is truly remarkable, harnessing the body's own early healing power, which leads us naturally to fetal tissue engineering.
Right. The next logical step.
This concept involves combining a matrix, like a biological scaffold, with stem cells to actually regenerate missing or malformed organs or tissues. Think about myelomeningocele, spina bifida again. It's not just nerve damage. It's also a complex defect involving bone and connective tissue missing over the spinal cord.
That covering is crucial for function.
So to really restore function, you need both nerve repair and proper tissue coverage. One approach uses placenta-derived MSCs, PMSCs, combined with an extracellular matrix ECM scaffold, like a high-tech stem cell-infused bandage.
These PMSCs showed neuroprotective effects and improved motor function in fetal sheep MMC models. That's promising.
And the future vision.
Even more ambitious, imagine a bone scaffold seeded with PMSCs to provide complete tissue and bone coverage over the defect, preventing postnatal damage, truly rebuilding the missing structure.
Wow. Are there other ideas?
Yes, other cool approaches too, like a gelatin-based sponge engineered to slowly release fibroblast growth factor. That's a protein that encourages new blood vessel growth angiogenesis. The idea is to attract the fetus's own stem cells to the area and stimulate them to regenerate a healthy tissue layer over the MMC defect. It's about amplifying the natural fetal development process to rebuild what's missing, almost like guided tissue regrowth. And if you connect all these dots, we arrive at the ultimate in precision medicine: in utero gene therapy. The concept here is just astonishing, correcting life-threatening genetic abnormalities by leveraging the unique developmental stage of the fetus. For monogenic diseases caused by a single faulty gene, like cystic fibrosis or hemophilia, the idea is to deliver a working copy of the gene to replace the defective one.
Has this been done?
In animal models, yes. For example, using a harmless virus called an adeno-associated virus, AAV, as a delivery truck for in utero gene transfer, UGT, for hemophilia B in primates. That showed long-term, safe, and effective expression of the new gene. The animals produced the needed clotting factor.
But the real buzz is around CRISPR, isn't it?
Absolutely. CRISPR-Cas9 gene editing technology has immense potential. It allows for precise cut-and-paste editing of the DNA itself, correcting the genetic error at its source. We've already seen studies where delivering CRISPR reagents into the amniotic fluid in fetal mice resulted in specific gene editing in the lung cells, the pulmonary epithelium. They were able to correct a genetic defect mimicking cystic fibrosis in those lung cells.
Before birth.
Before birth. These results show the incredible potential for gene editing to restore lung function, treat inherited disorders, potentially rescuing fetuses from otherwise lethal diseases before they even take their first breath.
What are the hurdles?
The main challenges are perfecting the delivery, getting the gene editing tools to the right cells efficiently, and critically, doing it without affecting the mother, who is, as we keep saying, an innocent bystander in all this. Avoiding off-target effects is paramount.
Okay, and finally, something that really does sound like pure science fiction but is getting closer. The artificial placenta, sometimes called the biobag.
Yeah, this one is truly futuristic sounding.
The problem it tackles is profound. Extreme prematurity. It's still the leading cause of infant death and lifelong disability. We've pushed viability down to maybe 22 or 23 weeks gestation, but babies born that early face huge hurdles, especially with their lungs. They're just not ready. They often need harsh ventilation, leading to chronic lung damage.
A huge challenge for neonatology.
So the biobag, it's basically an external womb.
That's the concept. An extracorporeal system outside the body designed to continue gestation for these extremely fragile newborns, supporting their physiological development.
How does it work? What makes it special?
It has some really ingenious features. First, it's pumpless. It uses an arteriovenous circuit, meaning the fetus's own tiny heart provides the power to circulate the blood, just like through the umbilical cord naturally. It mimics normal physiology. Second, it's a closed fluid environment. It keeps the lungs filled with fluid, which is essential for them to develop normally, just like in the real womb. And there's continuous fluid exchange. Third, it connects via the umbilical blood vessels, allowing for a potentially smooth transition.
Has it worked in animals?
Yes, remarkably well in fetal lambs. They've been physiologically supported in this device for up to 4 weeks, and after birth from the biobag, they showed normal development and function, even thriving.
Amazing. Are there still questions?
Oh, sure. Like, how important is the specific composition of native amniotic fluid for long-term development? That's still being researched. But the potential implications are enormous. It's not really about pushing viability limits even lower, say below 22 weeks. It's about dramatically improving outcomes and quality of life for those babies already born at the very edge of viability.
Turning survival into healthy survival.
Exactly. It could mean the difference between severe lifelong disability and much better health. And looking ahead, it could also be crucial for safely isolating the fetus during those advanced stem cell or gene therapies we talked about, reducing maternal exposure, making those experimental treatments safer and more accessible.
Thinking about the big picture then, what this really means for you listening is that the boundaries of what medicine can do are being pushed in ways that were unimaginable just a short time ago. It's offering real hope where maybe there was very little before. So after covering all this ground, what's the big takeaway? We've gone from an idea called radical and heretical to a medical reality that saves lives, improves lives for lethal and non-lethal conditions. It's a field defined by relentless innovation, constantly evolving techniques, and a truly remarkable improvement in safety for both mother and baby. It's really an ongoing story of incredible perseverance and discovery.
It really is. This field truly exemplifies how persistence, deep multidisciplinary collaboration, and just relentless innovation can overcome hurdles that seemed insurmountable ethically and technically. It's not just about fixing things, it's about fundamentally changing the trajectory of a life, offering a future where maybe none existed. And this raises a really important question, I think, for you, the listener. What other conditions, things we currently think of as incurable, might actually become treatable in the earliest stages of life now that we understand this potential for intervening before birth? The implications for preventing or reversing disease at the earliest possible moment are just staggering. It goes way beyond fetal health. It could give us fundamental insights into regeneration and healing for people of all ages.
We really hope this deep dive has given you a fresh perspective, maybe some truly surprising facts about where medicine is heading, the absolute cutting edge. Keep that curiosity alive, because there's always, always more to learn.